So today, it's really an honor to be asked to talk about this topic. A few of the chief residents approached me last spring after the iCOMPARE data came out and said, can you talk about this? Like, oh, okay. But I didn't want to just do iCOMPARE because we have a lot of data from our own program. The title of this is more creative than I am. I was sitting with Courtney Tugel in the women's health precepting room and with a few of the residents, including Sean Bell, and said, I need a spiffy title. And so they were playing around with the I. So I want to give them credit for this. So, of course, what Courtney said was, I work, I burn out. And I thought, well, that seems a little negative. So let's, I hope we can have fun with this, although this is a serious topic. I think there's a lot along the way. I'm going to try in the next 40 minutes or so, 45, to cover this and then leave some time for your comments and questions. So here are the major things we're going to cover. Many residents feel like they want more history of the program. You know, we in residency have this little window of life didn't begin until we began medical school. But then in residency, just sort of what did happen before, and I thought it'd be kind of fun to look at a brief timeline. How do we measure and define burnout? The iCOMPARE studies, and then I wanted to go over the 3 burnout studies we did over an 11-year period at the University of Washington that was published in 2017. We're focusing on residency, but what about before and what about after? So we'll touch on that briefly, some strategies to reduce burnout, and then adapting to goals of the future workforce. So some caveats and starting points. I'm going to take these as a given. I think we would all agree resident wellness is critically important. ACGME training is extremely complex. We need to think about the patient care continuum, handoffs, but what is a good training model for residents? How do they learn? In what setting? How much sleep do they need to do that? And it's hard to reconcile all of these competing things. And so clearly we've had no one solution. And I want to emphasize residency is not easier now. I always tell our residents and students when I'm on the wards is as soon as I say, when I was a resident, you can stop listening. Because life is so different, but you have to give me a little license here in the next few minutes. I am going to say when I was a resident a few times, and then see if we can drop that. We all prefer our own training model. I think that's pretty clear as we look at data. People like what they've done before. And hours are an important issue, but they're just one part. And so we won't go into the details, but residency, for those of us who do ward attending, and I'm still up there 6 weeks a year, it is so complicated. And then we can learn from millennials. They're good people. And they are going to, nobody wants to admit they're a millennial, so I'll have to define that in a bit. Okay, so timeline of residency. Where did we start? So in 1893, this is, of course, an image of Dr. William Osler, who at Johns Hopkins actually created the modern residency system, really focused on the emphasis on the patient, but also, these models of residents at the bedside, or people in physicians in training at the bedside with him. In 1910, the Flexner Report, which when I was in training was talked about a lot as a history thing. It's complicated. Flexner, I think, had, a lot of prejudices, but what he was trying to do was to say, we need scientific rigor in medical schools. We can't just have medical schools run by doctors who are making money. But so many people, including Osler, were very unhappy with this. He thought that they were taking away the emphasis on the patient. And so it was messy for a period of time, but I think where we've gotten to is reconciling the uniqueness of the science and the caring of patients. Then we get to 1950, where interns still lived in the hospital, and I remember Dr. Brody one time mentioning her father, Dr. Holly Smith, who was chair of medicine at UCSF for many years, who was not allowed to be married during internship. Now, this image, I don't know if these people look familiar. These are actually my parents, taken in a photo booth when they were engaged about that same time. They were not in medicine. They were farmers. And I like to remind us that it is not just in medicine that people work very long hours. This was an image we found in a box of my mom's, and we had to recreate a very dog-eared little 2x2, but it was kind of cute. Anyway, so then in 1977, I think, as we started thinking more about primary care, the residency program here established the primary care tracks. The whole WWAMI program started with the School of Medicine. And then when I was a fourth-year medical student, the Libby Zion case in New York. Some of us remember that case. So Libby was an 18-year-old in a college in Vermont, had become quite sick with a flu-like illness, got admitted to the New York hospital, and basically died over the course of the next day. She was on an antidepressant. The residents taking care of her had seen her, but then over the course of the night, calling with more and more symptoms, and she was given an equivalent version of meperidine, which is a generic of Demerol. And the nurses were calling the doctors over the course of the night, did not go see the patient, they were too busy, and ultimately she got a temperature of 107 and died over the course of the next hours. They had not seen her before she died, and so it raised this whole uproar about, you know, can we take care of patients when we've got too much else going on, when people are tired, and they didn't stop to think about. Now, in hindsight, many people think she had serotonin syndrome, but there were lots of debates about that. So it was a really important time because it was one of the first that people really talked about this whole issue of effective sleep deprivation. And then when I was in international medical school, graduation picture of me, we had residency call Q3 and had 1 day per month unenforced off. I remember in R2 on one of my hospital rotations saying, well, I hope nobody wants a day off this month because I got to go to a wedding. And we were all like, okay, you know, it's what we do, we work. But, you know, residency was so different then. We may have taken care of a ton of patients, but we didn't have all the complexities and things. We didn't have the pace, which actually really the pressure. And nobody was telling us, now, what time did you discharge this patient? And, you know, all those pressures and quality monitoring that we have now. So then we get a little bit more recent, the end of the 20th century. So I have a photo of one of my mentors when I was in the residency program as the associate director of the program with Dr. Wallace. So in 1986, I wasn't in the residency until the end of 94. This major study out of Portland on depression. And they showed that the nadir of mood in residency was February, March of internship. Things did get better over the course of residency, but that was a really important thing, which was studying residents over time for mood changes. In 1988, by the way, so the Libby Zion case was still being discussed nationally. That was when the VA hired team coordinators, both on the wards and in clinic, to try to help reduce the hours being spent on paperwork, tracking down charts, et cetera. The reason this was one of my first papers, actually, because we thought, oh, we need to study this. And then ACGME, as some of this data was coming out, started focusing more on education requirements. At this point, the New York State adopted, the legislature adopted an 80-hour work week. You'll see it took almost a decade for that to become national. So that was a really big deal. There wasn't actually a lot of data about how they did it. They just added a lot of other providers, including PAs and nurse practitioners, added physicians, but they really tried to enforce a work week. And then, just in case you think, like, way back when, how did things change? Before 1991, categorical residents weren't even required to have clinic in the intern year, and only had a 2-month block of clinic in 3 years required. And then in 1991, I think one of the reasons I was hired as the clinic site director was to say, how are we going to make this work? To actually have clinic all 3 years and to start adding more ambulatory training. And then in 1992, a few years after I finished residency, we created the residence teacher course. And the reason this is important for this talk is that, you know, there were a group of us faculty and residents talking about what the content should be. And we're focusing on work rounds, you know, attending rounds, leadership skills, the 1-minute preceptor. And the residents said, we need to talk about morale. And I was really proud of them for adding that to the issue, saying this is an important part of being a team leader. And then just started the retreat and so on. And into the 2000s, Kelly, who's swinging her way on an African safari as we speak. And then just over the course, so we started the burnout studies here. You see 2001, 2004. ACGME enforced, we'll come back to that, the 24+6 in 2003. And then one of the biggest changes recently, which relates to iCOMPARE, is actually having this new rule of having 16-hour shift limits for R1s. And so then the iCOMPARE came as a result of that in programs on happiness. I empathize with the program directors, with Dr. Jennifer Best, the APD for Wellness. How do we manage all of this stuff? So we are not talking about all of this today, but I want to just, this whole scope, as we focus on burnout today, just reminding us mood disorders are highly prevalent in residency as they are in our society, and these are really a big deal. Sleep deprivation, what are the consequences of that? Empathy. So there was a really nice study back in 2002 that showed that empathy diminished rapidly from the start of internship down to the nadir about 5 months in. Did come back up, but never actually reaches the point of starting residency, which sometimes for our really difficult patients, trying to align, the empathy, in some ways, you might argue empathy has to decline during residency as we're taking care of very challenging things, but empathy might be the reverse of burnout. And so these are complicated issues. And then burnout, if we focus on the original definitions of this being an occupational related issue, that it only affects us at work, and then issues about, is our work valued? Am I beating my head against the wall day after day and nothing's happening? And then the personal investment. Do I feel like I'm accomplishing something, or am I getting emotionally exhausted? And then there is something called hardiness. Some programs actually measure that, and that might be resiliency, adaptability. I don't know what to do with that one. And so let's define and measure burnout. So Dr. Christina Maslock, who I think, as I've learned more about her, an absolute unique individual. So she was a social psychologist, got her PhD at Stanford, and has been at UC Berkeley. In 1981, authored the Maslock Burnout Inventory for individuals, not just in medicine, but a variety of high stress occupations, like where there's a lot of service involved, teachers, police, and so forth. And she has modified it a couple times, but the 22 item 1986 one is the one that we use. The other thing Dr. Maslock is known for is that at that time at UC Berkeley, there was a study going on where subjects had a recreation of being in prison. And she thought that was horrifying to study the impact of being behind bars. And actually, as she learned about this study that other investigators were doing, she got it stopped within 6 days. And she married the lead investigator, which was kind of an interesting thing. But anyway, there's a whole lot about Dr. Maslock. So I just was really impressed that at that point that she was able to make that much influence. And I think really up until the last few years, her inventory is how burnout is measured. So there's 3 scales: emotional exhaustion, depersonalization, low personal accomplishment. Each item scored on how often it occurs. And the problem, as we'll come back to, is that many people have reinterpreted this. She also felt that you shouldn't say, I'm administering a burnout survey now, that it was a study of wellness, because we might bias individuals. As we'll see, the more recent surveys actually explicitly say, I'm asking you about burnout. Okay, so the single items that we're actually using in the VA, so lots of work done by Dr. Kari Nelson and Dr. Greg Stewart in the VA, looking both at the primary care but also other specialty data. And the VA Centers of Excellence in Primary Care Education are using this one question. So it has been validated in physicians in relation to the Maslock Burnout Inventory. There's a 1 to 5 point scale. Overall, based on your definition of burnout, how would you rate your level of burnout at work? So 1 is, I enjoy my work, have no symptoms of burnout. 2, don't always have energy, but don't feel burned out. 3, have symptoms of burnout, physical and emotional exhaustion. 4, burnout won't go away. Think about frustration at work a lot. And 5, I feel completely burned out and need some changes or help. So people meet the criteria for burnout by having 3, 4, or 5. And some have broken it out. The 3 is getting burned out, but it falls under. I'm not going to ask you to tell me how you're judging yourself at the moment. We can come back to that. Okay, iCOMPARE. So many program directors were a bit outraged. I must admit, I wrote a letter to Dr. Naska myself of ACGME that we are making changes without ever having evidence. The biggest evidence for switching to a 16-hour work day for interns actually was based on some theories, but of little limited data on sleep deprivation in physicians. And so it was really about sleep deprivation. One of the biggest studies cited was very interesting. It was a Boston study where R1s were randomized to a 64-hour work week versus the usual 80. Now, it was an ICU study. The problem is the senior residents still had 80 hours, and the attendings were much more involved in the patient care. But in the arm where residents had 64-hour work week, there was at least a trend towards less errors, fewer near misses, and so it actually, the conclusions were that there was benefit in patient care outcomes by reducing hours. I will say that I participated in a workshop with the authors of that study, and it was fascinating to hear them talk about behind the scenes, attendings saying, you know, we just basically took on a lot of the care with the senior residents. So then it's, well, as you have more experienced individuals, you're going to have better patient outcomes possibly. But the other thing they said that was very interesting is they had done some time studies of how much their interns got sleep. The interns in the 64-hour work week did not get more sleep. They did more socializing. They did more other stuff, which may be good. But some of the authors said, we can't believe they admitted that. But it's a study that is actually cited quite a bit as a rationale for why this was done. So, you know, basically what the iCOMPARE then was to say, let's actually study this. Let's randomize programs. The I doesn't mean I, or me, it means inflexible. So the way that's reported in the study is the standard schedule, inflexible meaning the 16-hour shift for interns, versus programs being allowed to go back to doing, you know, overnight call, the 24 plus whatever. I thought the 24 plus 4 was still in place. So that whole year that our program participated, I was getting my residents out at, 10, 11 in the morning. And then I found out later that wasn't actually required. So anyway, we'll be looking at that data. So this is just pulled from the trial. This was reported in late March online in 2018. So it caused quite a series of discussions at the upcoming program directors meeting that I heard about the discussion shortly after. So what did they do? They basically, this is just defining sort of what we talked about. The two groups, oh, by the way, so programs that they weren't required to participate, they could volunteer to participate and they would be randomized to one of the two arms. The UW did participate and, as you may know, was randomized to the flexible, where so the programs could essentially do what they wanted as long as they stayed within 80 hours and 1 day a week off. So our program was randomized to that and participated. So basically the flexible programs had no restrictions on the residents' shifts. The standard, again, the inflexible, had the duty hours for interns of 16. The PGY 2s and 3s couldn't exceed 24 plus 4. And then some mandatory time off, more extension here. This was at least 14 hours after, if they chose to, after 24 hours for seniors, and at least 8 for interns. And no difference between the groups in the work hour week, the number of days off, or overall frequency of call. So just to mention briefly the programs participating, there were a lot of eligible programs that didn't participate. They didn't want to change what they were doing. And then eligible programs, there were approximately 30 in each group, and those were very similar. It was a mix of, as in the overall total representation in the country, and similar community, university, or other mix. And so just briefly to mention the percentage of observed shifts. So flexible programs did have percentage of shift time. Direct patient care, a little bit more on the flexible program side. Education was no different. Secondary outcomes about indirect patient care, handoffs were less in the flexible rounds, little bit different in this, but not significant. And then some other changes as sleep and so forth. So since I co-direct board review courses for 25 years with Dr. Powell, I have to have at least one question. So before I give you the results, what do you think? If you know the answer, please don't shout it out. What percentage of internal medicine residents in iCOMPARE programs randomized to the flexible hours, meaning again, 80 hours, 1 day a week off, but could have overnight shifts of 24 hours, met burnout criteria in the depersonalization? 35%, 45, 55, 65, 75, or 85? So for those of you who don't know the actual results, just shout out, what do you think? 85, almost universal, okay. C, okay, more in the 55. Nobody down in the 35, 45%? Okay, so some of you are optimists, okay. All right, so it was 75%. This was highly concerning. Same question, what about those randomized to the R1 standard schedule with 16-hour shift limits? So what do you think? Shout out. 75. 75. Anybody think it would have been different? Quite a bit different than the other arm? So this was highly shocking to program directors. I'm not sure why, but it was. Because I think the idea was, if we can, have residents have less sleeplessness, have perhaps a little bit different, schedules, we would hope that if that's the reason why this was done, that this would be better. So it's not statistically significant between the groups. So this just shows you not only what we just mentioned, which is the depersonalization, but actually in the emotional exhaustion, using a pretty high a score cutoff here. The flexible programs, emotional exhaustion, 79%, and the standard programs, 72%. I mentioned these data, and then personal accomplishments. So these two are high, so you say a high level of, or a low personal accomplishment, which overlaps actually, and it's 71 and 69. So we haven't solved this, I think would be the take home. And a little bit more detail about interns. Now, interns are special people. They don't think about duty hours the same way senior residents would. We found that in our studies, and so did iCOMPARE. So without looking at every single item, I've highlighted, so essentially they were saying the percentage who responded that their program design had a negative impact on their training and personal experience. So I'm just focusing on the ones with odds ratios more than 3. They thought that the flexible program had negative impact on professionalism, job satisfaction, career choice, morale, time with family, friends, to pursue hobbies and outside interests, and their health. Not what the authors thought, not what senior residents thought, and not what program directors thought. So this is not showing you every table, and you can study this if you wanted to look into the study in more detail. This is the survey responses of program directors. So essentially we're looking at dissatisfaction with the learning environment. So how many perceived dissatisfaction or negative impact, and this is the flexible and standard programs again, and then looking at the odds ratios. So standard programs, actually the program directors thought that had a negative impact on a significant percentage, so 23% of interns and 10% of their senior resident experience. The ability of interns to manage the patients they admit, program directors thought that was negative in the standard. Morale, program directors thought that was much more negative. Again, did not really correlate with the intern survey results. So, you know, we as program directors may not understand our trainees very well. And then just a few other highlights here. Effectiveness for performing clinical duties. Program directors thought that was more negative for the standard programs. And then, interns, ability of the attending physician to provide feedback and for patient care, thought it was much more negative for interns and seniors. So overall, what did iCOMPARE tell us? High rates of burnout in both arms by the burnout inventory scales of emotional exhaustion, depersonalization, and low accomplishment, not significant big differences between the two. And remember, they still worked a lot of hours. So then the question was, what about the knowledge acquired? And they had several different ways they looked at this, but the most was the ITE, the in-service training exam scores, and looked at non-inferiority, and essentially they were within a point of each other. Preferences for training, just to summarize what we just looked at, R1s prefer the standard schedule with limits, R2s, R3s, I didn't show you all the senior resident data, and program directors preferred the flexible schedule. Surgery programs about the same time or the year before did have their own trial. We aren't going to have time to go into the details, but they actually showed similar preferences. The attendings and more senior residents felt that the old schedule, the working overnight, was good. The interns didn't like it. And I will say there's been other reports on patient outcomes that show no difference. Some of us have really emphasized the handoffs and things like that, and maybe we've learned from the hospitalist design of practice that it is okay to hand patients off. And then there's other studies looking at the sleep deprivation. I will say also that the response rate in the study for the surveys and completion was about 45%. So you could argue, did they have enough to have this be an important thing? So what about our program? I went upstairs to Sean's team and took this picture the other night. They're on call. It was 6:30, and I got to tell you, that team looked pretty darn happy sitting there. But it was only 6:30, and I said, now, you know, if I take your picture, you have to agree to have it be broadcast around the region, and nobody left the room. But the one intern never got off the phone either. So, okay. So why did we study this in our program? And I was in the residency back in 2001. But in 2000, Tate Shannenfeld, who was in R3 in our program, came to some of us and said, I worry about what I see happening to me and my fellow residents. I feel like we don't care as much anymore. Can we study this? And is this empathy loss or what? And Dr. Tony Bach said, I think what you want to study is burnout. And I said, you know, I think our morale is pretty good in the program. Sure, let's study this. I am not sure if I knew in hindsight the results that I would have wanted to study it, you know, or what was going to happen if the world thought that we had high burnout rates. I will say before this, there had never been a study done of internal medicine residents. There had been a tiny study done in family practice. So our first study in 2001, we'll go over this. Then in 2003, one of the major duty hour changes occurred, the 24+6, and so we did another survey after that. We used the Masluck burnout inventory, and then after the 2011 changes, we did our third survey. Again, same study design. We also asked a lot of questions about what are stressors for you, what helps you to cope, things like that, and we won't go into that. So our objectives in 2012 were to do the third study and to compare with the others and look for trends both in well-being and burnout prevalence. So we did include the 2-item depression screen, as I mentioned, the Masluck burnout inventory, career satisfaction, and questions assessing their perception of the impact of the latest duty hour changes. So These slides are from Mike Krug. Dr. Mike Krug over in Boise is the APD, was at the UW and a chief resident here, and he's coming over for ACP, I think. Okay, all resident physicians. So basically the first survey was just kind of a baseline. This is the one Dr. Shanafelt initiated with us. All resident physicians, then these changes, July of 2003, our second survey, and then the latest in 2011, and then the new survey. So I like to restate, this is a complicated design. So the demographics were pretty similar. I will say the interns were more likely to respond, but we did have an overall high response rate in the surveys, which was over 70% for all three. So gender differences, married, and not much difference in this, as I said. So well-being indicators did improve over time. So looking at meeting the burnout criteria, as I said, when this results came out, we published in 2002, I thought I might lose my job. 76% of residents met the criteria for burnout. And there's lots of details in our first paper about exactly how you have to score on the scales and things like that. We won't go into that. Dropped to 64% in 2004 and down to 61% in 2012, which again versus the iCOMPARE data that was collected in 2016-17 of 75%. So you go, well, maybe we're 15% better than the nation. So kind of, let's hope for that. But by the way, the burnout criteria, that was not a significant change over time. Happy with career choice did improve. And also after the first study, we initiated a whole variety of things to work on wellness in the program even further. Actually some support groups with peers. We had psychologists and psychiatrists working with all these different groups of residents. Over time, gradually those things faded as there just became more established things in the program and personally. So the happiness with career choice went from 66 to 79% over that decade. And positive results on depression screening went from 45% to 31. And that was statistically significant. One of my take homes here of this whole talk is to remind us that as we talk about burnout, we can't forget about depression, suicidal ideation, all these other mental health issues that actually can have really profound effects. The incidence or prevalence in the general population in the US of depression positive screening is about 25 to 30%. I asked several psychologists and psychiatrists in the last few weeks, so what percentage of people on that 2-item positive will test positive on something like the PHQ-9 or the more definitive? And none of them could tell me. Most of them thought it was almost all. So, but just to be aware, this was the 2-item screen. So I think we did make some impact over the last decade on at least a trend towards improving burnout, happiness with career choice, and reduced depression over time, with very intense efforts on the part of the program in this whole time and subsequently to work on this issue. And then just a little bit about this, I want to keep going, but just we won't review all these numbers, but the take-home senior residents thought that the duty hour changes to the 16-hour shifts for interns were negative. The interns were okay with it. Then we asked explicitly on the last survey, would you like us to revert to the old duty hours? And senior residents said yes, and interns didn't think so. So the strengths of this study were, just this identical instruments over time. These really were anonymous. We worked really hard with the IRB to make sure that they were. And then, of course, the limitations of only being one study. I think we've kind of touched on these outcomes. And I said, Dr. Krug, how is it you get a picture of your baby in my grand rounds? But anyway, this is Julian with Mike when Mike was in residency, when Julian was born, both sound asleep. Okay, so what about before and after? And there's a lot of data. So Dr. Shanafelt and Dr. Lottie Derby, who is also a resident in our program, they both subsequently were at Mayo Clinic, have been there. Lots of data about medical students. The UW has participated in many of those studies. The burnout has a high prevalence in medical students, but it's very it changes a lot over the course of the medical school. So around the time of high stakes exams, burnout goes up. There's a lot of association of burnout with depression, with suicidal ideation, and other stressors. And at the start of residency, at the end of medical school, it was like, we did it. Actually, burnout rates are pretty low. People are very excited at the time they're going to start residency. And then, as you know, we're like, okay, they start residency and we screw it all up. But I think it's worth pointing out that burnout does not just happen during residency. The faculty data, I've been really struggling with how to present this. This paper, so the whole issue of JAMA in September 18th issue, if you want to try to find that, is all these different studies of burnout. And so the one I want to highlight here included 110,000 physicians in 45 countries. And the authors hope to try to come up with what are some typical burnout rates of physicians in practice. I say faculty, of course, faculty are only about 5-7% of physicians in the US. So lots of different types of practice. Anyway, they couldn't even do a meta-analysis. The heterogeneity of the study designs, although the majority, actually 60%, used the Maslach burnout inventory, there were different interpretations. What number did you need on the subscales? And I would say the authors ended up throwing up their hands going, we need to study this. And so it really, the quality isn't great. We did I don't think I was an author. I think I was an advisor on Dr. Lara Goiten's study of faculty after our first burnout study, looked at the different major departments in the School of Medicine, and the burnout rates were between about 25 and 40%. So anyway, I think we had hoped, these reviews would show us something, but even more than that, this editorial said, what do we even do with burnout? How important is it? And, I kind of feel like the ship has sailed, but these authors and editors were trying to say, we need to get some really good data. We need to have much more standardization of what the instruments should be. And can we, is this even, I think I don't agree with the editorial where they say, let's just start over. Because I feel like things like iCOMPARE use the same thing. They had lots and lots of individuals studied, but I just want you to be aware there is some controversy in the literature about the scientific rigor of these studies. I don't have time to present the primary care data in the VA nationally, but the burnout rate has been as high as 50%. It's a little bit less for some of the other specialties, high for neurology and psychiatry, but also a lot of efforts with working on practice things that we are seeing some changes. I also will say that in the Center of Excellence, where faculty are very engaged in innovation and looking at staff and faculty that are burnout rates, no one had a 5 and 26% were either getting burned out or the 4 on the 5 scale. So I think there's things that we can do that can reduce this, but just to take away from this, high rates of burnout and from the start to as we go forward. So what causes burnout? Dr. Maslach focused on several. Work inefficiency, those things that's like, I just can't get done what I need to do for my patients. More volume of work, the demands exceed how I can actually have time to get it done. Lack of autonomy and meaning, and I would say over time, she didn't focus a lot on work hours because that just wasn't the issue in 1986, but that has been added as the fourth. She also emphasized the importance of uncontrollability. And I think if we think about what is it that drives us crazy at work, that makes us feel like our work isn't meaningful, it's the things we can't control for. And residents are the epitome of that. You get to make minor changes in your schedule, but you don't get to change a lot of that. You may feel sort of powerless at the hospital sites. Also, I'm only going to be here for 4 weeks, and although this is a terrible problem, it's not my problem, but still feeling powerless to make some of these big changes. The other thing that Dr. Maslach emphasized is the variability in what bothers us in our work. So I might be really bothered by this issue. This patient has been on our service for 90 days, and why is it we can't get him out? And residents are like, I just write my note every day. It's okay, somebody else will worry about it. But they might be really bothered by something else. So there's a lot of variability, which makes it hard to then figure out how do we fix this. So strategies to reduce burnout. This is kind of a summary of the literature, my informal polls, and just emphasizing the other well-being components. This is a busy slide because I kept wanting to add more pictures, but the strategies that have been emphasized and we found in our first study, and just looking at the recent 2018 hospitalist meeting program, a lot of discussion on all of these different things. Talk to your peers, your colleagues, just getting support from other people who are going through the same thing. Remembering, what can we do to make work more satisfying? The focus on teaching. I mentioned the through it, the intensity, you'll come out bigger, stronger at the end. Is that really true? And nobody's ever going to do that schedule again, whether we do inpatient, outpatient, or some mix. So, as one of our program directors said, why do we keep making people do this? Now, there's reasons. There's the patients who need to be taken care of, and who else is going to cover, and costs. But I think at some point there's going to be a day of reckoning about that. And how soon? So millennials, think positive. I'm not talking about negative things about millennials, but I will say on my last ward rotation in June, the students said, Dr. Wipf, can you be sure to mention on your evaluation that I work hard? So many people are biased because of our age. One prior site attending said, you millennials just don't want to work. And the students said, we get this all the time. And they really felt there were a lot of prejudices about that. So I want to acknowledge one of the best talks that I went to, that we had at the VA in years, was actually Josh, I'm going to mispronounce his name, but Horecki. He's based in the emergency department, really has tried to study this issue. And then the millennials in my life, the late 20ers, I got a bunch of ideas. So I think the difficulty, you could generalize about any of our eras or generations, and others could be negative. So we need to be careful about that. We also need to recognize other generations may admire us, but that doesn't mean they want to be like us. I do think millennials bring fresh perspectives. They want to participate in broad change. And just to remind us, so when we did this thing at the VA, we said, how many people are millennials? And there's all these students and a few residents sitting there, none of them raised their hands, like, hey, you guys, you got to admit it, we can tell. Anyway, millennials had been defined as 80 to 2000, but as Dr. Maya Bomstick reminded me, we're not millennials, we're exennials, so the early 80s. And, again, I think people have made these misperceptions that millennials don't want to work, that they don't, da-da-da-da-da. Anyway, they account for a ton of people and most residents. So lots of things contribute to this unique group. Increased focus on a lot of different things that you can see there. And I think these 5 things really sort of summarize. Millennials, I think, more than many of us in our careers, really want to make a difference. They want to make a difference quickly. I mean, I have our 3s talking with me about positions going, so when can I get in a leadership role? Like, well, not the moment you finish. But, it's like, or can I get mentoring to help me get into a leadership role? Or, people want to make a difference. And I think, as my daughter worded it, she said, we want to have work that has value, and we want other people to value it. And that, I think, is the crux of residency. A lot of different things we do don't feel like they're that well valued. Communication, lots of different ways, desire feedback, transparency. Of course, the first digital natives want opportunities for growth and access to, as I said, career opportunities. And what Josh talked about, a full life, my daughter added work-life harmony. I don't think any of us call it work-life balance. I, for years, have been saying work-life integration. And Mackenzie's like, no, you need harmony. I'm like, well, yeah, right. Okay, anyway, conclusions, and then I want to hear from you guys. Very high prevalence of burnout. It is somewhat debated as to exactly what this means, but I think most of us would say this is an important issue. And I would say, based on everything I've studied about this over years, is I think it is a marker of intense work stress. Originally, burnout was that you could have burnout, felt really stressed at work, but you could leave and go home and enjoy dinner and, all these other things in your personal life. If you couldn't, it was more like depression. There are burnout study design issues. We've touched on that. The premise of fixed hours, fixed burnout probably isn't sufficient alone if we're not going to address that we still ask our residents to do 80 hours, which may just tie into a lot of problems. The uncontrollability, how can we give our residents more autonomy, more engagement in making changes? Now, I appreciate that as program directors, we can get really frustrated when, can you fix this, this, and this, and this, and this? At our retreat on Monday for COE, I'm like, okay, guys, you got to prioritize a couple things, and so I think sometimes, but then how could they help us to make changes? And I want to emphasize, don't forget about depression. A third of our residents will have significant depression during residency. So, and there is some overlap with burnout and depression. I sometimes think we've touched so much on everybody's burned out that are we thinking about that? Millennials have goals, talents. Oh my gosh, our residents, and I think of John Geyer. I mean, he's doing more with our telemedicine, telecommunication. He's even fixing how we do our fax machine. It's like these are things we haven't quite. And then in the U.S., residency design is this old time-honored tradition. But is it the right model anymore, or do we need to dramatically recreate? And in the meantime, we all keep trying to make the program even greater. So I'd like to thank 1 million people, and I've listed many of you here. And many people contributed to the talk, but I would say just in my daily life, it is I feel inspired and positive from all of my residents and students and my faculty and all of our leaders. And my patients remind us why we're here, and my family, they let me do what I want and still love me. All right, with that, thank you so much. I'd be happy to field comments and questions.